Any disapprovals? Seeing that there are no disapprovals, we will, seeing no disapprovals, then the minutes are approved. Karen, do you want to give the director's report?
Yes, I would be honored to give the director's report for everybody. Just a brief overview, because I know that there's so much else to share and discussions to have, and we also have something exciting to share that I'll mention to you just in the director's report. So this one is the team. There's another one. It says director's report. It's not COVID-19 and Medicaid. It's another. There it is. Thank you. So you saw a little bit of the excitement, steal the thunder a little bit. We have some statistics to share with you about our members and service utilization related to COVID, and we're doing a deeper dive related to health equity. So I'll have Dr. Ellen Mons presenting that in just a few minutes for you. But just going to give you a quick update on all things happening here at DMAS. And so, we always work and talk to you about our team, our wonderful team here of 700 strong individuals. And we've been teleworking since March. And there have been a goal, and we call it Operation Homecoming, to begin migrating back into the building. And initial plans which were approved by the Chief of Staff were for us to start migrating in September, but with the steady increase, still holding steady in Virginia, but with certain outbreaks happening related to COVID cases, and also in consultation with other state agencies and also other corporate groups, we have decided to wait until January to begin moving individuals back into the building, just to, keeping safe precautions for our teams, because our health and safety is always first in our minds. So as you can see here, this is our proposed phased-in transition beginning January of next year. But until then, we have an off-site location. We have our Chief Financial Officer, Mr. Chris Gordon, is there with other key leadership to help make sure the daily work goes smoothly. And then, of course, everyone is settled in and working very well from home. So just wanted to give you a quick update on Operation Homecoming for us. Before we leave this page, I do want to mention one personal note, just very exciting, that you may not see that Rachel is on with us, but she had her baby, a beautiful baby girl. We call her Emma. And mom and baby and family are doing wonderful and well. And we are very honored to have Miss Sarah Samet, who is acting in her place. And so for the members of the board and to the public, if there are any issues or things that you need, Rachel or handling, Miss Samet is more than ready to help and support the team. So just wanted to mention that wonderful news and also acknowledge Sarah on the call today. Okay, next slide. So everyone's always interested in knowing how are we doing and how are we growing in Medicaid, especially with COVID happening. So since the state of emergency, as you can see, we have gained 136,000 members. This changes daily. This was as of September 1st. We have added over 81,000 new members to the Medicaid rolls that we did not originally forecast. So that is directly tied to the COVID experience, and we are very honored to have them all on the program and benefit receiving health coverage. And on average, as you can see here, we are gaining between 4,800 and 5,000 new members each week. So people may have assumed it were all adults, but we're also seeing children gaining access to the benefit as their families lose health coverage. And I was just on a national discussion yesterday, and that is happening all across the country because many families, once they lose their insurance, their jobs are going away. And so even if they find another job, they may not find other health insurance. So we do anticipate to see that as a trend moving forward. But just wanted to bring that to your attention that we have almost 1.7 million members now and growing on our benefit. Next slide. Just dive in. People love to see in the categories the individuals who we serve and support. And as you can see, the lion's share are children. 1 in 4 children born in Virginia are in our benefit. And so, 40%. Am I wrong on the statistic on that? But as you can tell, when you're looking at the numbers, when it says adults, and that's the third line, that number has grown significantly for us, whereas prior to Medicaid expansion, it used to be a much smaller number. So we also regularly update our data and have it available on our website. We've had some technical difficulties with our website recently, so it may be a week or two delayed, just in case people go out and take a look at that. But rest assured, we will be messaging and tweeting all of this information out to people to make sure they have the most current data available to them. Any questions by the members before I keep moving? Okay. Next slide, please. One other piece, and Michael, I think you alluded to this a little bit. We have numerous projects that we're working on at the agency. Typically, we have about 70 plus running at any given time. And but one I'd particularly like to bring to your attention, we dub it Project Cardinal, but it actually is a directive by the General Assembly to have us take a look at what it would take, develop a plan to combine both our Medicaid managed care programs, so that would be Commonwealth Coordinated Care Plus, and the Medallion 4 programs. So keep in mind, within 3 to 5 years, when the procurements happen for these two programs, that we would be combining them anyway. But in the meantime, the General Assembly has asked us to take a look at what would it take if we were to start next year in terms of merging the benefits. And as you can see, there are numerous components to this, and the team is working very hard in collaboration with our stakeholders and partners to develop the strategy and plan for what it will be, if there are necessary changes that will happen. And also we see it as an opportunity to better improve and streamline our program and make it as efficient as possible, not only within our agency itself, but also for stakeholders programs, and to better improve member care is always at the first and foremost of our minds. But as you can see, the plan itself, which will be released to the General Assembly late this fall, it's due in November, will include all these following components. So it's a very extensive work that will take to combine these two programs and benefits, but we see it as a value add for the program itself. And we dubbed it Project Cardinal. At some point in the future, we will be naming the program itself in its totality as a singular name, because we see the program as a critical safety net to serving many of our Virginians, and sometimes there's a stigma attached to the Medicaid name. And so many states have adopted names for their programs, such as Sooner Care and Badger Care, Medi-Cal, in order to help reduce the stigma and help people see that it's a very critical health insurance benefit. So we'll likely move to that point, but also once we have this information related to Project Cardinal to our board members, I'll be happy to come back and give you a more detailed update and also share the report with you. So the next piece I'd like to do at this point, I'm going to turn it over to Dr. Ellen Montz, is to provide you with some statistics and information that we're seeing related to COVID tied to our members themselves. And I'm going to go ahead and turn it over to Ellen, and you can go ahead and bring up her slides.
Great. Thank you, Karen. All right. Good morning, everyone. We have, as Karen said, I have a quick data spotlight for everyone. Our team has been tracking COVID-19 cases in our Medicaid program, and what we've done is we've taken the same approach as Medicare and CMS has taken with Medicare in terms of their analysis. So I just want to make the note that we are only using our claims data. We are not using any other information other than what we have in-house. So next slide, please. Okay, so this is kind of a recreated chart of exactly what Medicare kind of puts out every couple weeks. For the Medicare program, we've done it for our Medicaid program. And here you can see that in our claims right now, in our encounters, we have about 13,000 COVID-19 cases reported. Which works out to be about 786 COVID-19 cases per 100,000 members. Now, if you see the gray box there, starting in June, I would just highlight and note here that those bars are all conservative estimates because of our claims lag. So we would expect that as time goes on, we'll receive more claims that are associated with the weeks in June and July, which will inch those bars up, particularly those in late July. But if we have done kind of an overlay of kind of the total cases in Virginia by week to kind of see if we have any kind of disparate trends than Virginia writ large. And when we do that overlay, which is not displayed here, but we did that for kind of a sensitivity check there, we do, follow, the kind of week by week ebbs and flows same as Virginia writ large. All right, next slide. Okay, so here on this slide, we're looking at our cases in two ways. One, we're looking at kind of a rate within eligibility category. And then two, we say, okay, let's look at our total number of cases and how did that break down by eligibility category. So the first graph we have on the left, it is of no surprise that our aged population has a much higher case rate per 100,000 members. This is something that we see nationally. We see in news reports and statistics here. I will note that when we compare our cases per 100,000 members for our dually eligible members, so those that are enrolled both in Medicare and Medicaid, and we compare that to the numbers that CMS puts out for their dual eligible population, for the total dual eligible population across the country, we're coming in right there about at the same rate. So, and I think that probably checks out for kind of where Virginia is writ large on the kind of national case rate when we look over time, just about average. Another thing that obviously jumps out at folks is the pregnant women category and our rate there. Again, we don't have any specific way of teasing this out of our encounter and claims data, but this is something also that is seen nationally for pregnant women, and that is likely driven by the fact that pregnant women are tested more. In that they are, so we have kind of a lot of likely a fair number of asymptomatic cases in that bar there, and these pregnant women are receiving tests as they come into contact with the medical community. On the graph on the right, it's a common story, right? You have a higher prevalence rate within certain categories, but when you look at total cases and break it down by eligibility, we see that, children, for example, represent 23% of our cases. Pregnant women, 3%, adults, 36%. So kind of more breaking down, closer-ish to the distribution that Karen, presented earlier in enrollment, but for, kind of our aged, and our individuals with disability or blindness population. Okay, next slide. All right. This is our final slide, and we've broken down our COVID-19 diagnoses by our delivery system. First here on the left, and here we show that about 50% of our cases are in our Medallion 4 program. 33% of our cases are in our CCC Plus program, and 16% are in fee for service. And I should say this is measured by the first instance of the diagnosis in the data and what delivery system they're enrolled in. So we always say we are very close to 95%, or we're definitely in the 90s in terms of managed care enrollment. But we do see that 16% of our diagnoses show up when individuals are in fee-for-service. And really here, this is telling, I think, an incredible story about Medicaid and Medicaid expansion. And that is, it is a program that is there for individuals when they need it. So we are seeing likely, although I can't say for certain yet until we dig in more to the data, that these are individuals, the 16% here are individuals that are newly getting coverage and are getting this coverage at a time when it is incredibly needed. Not only for the individual, but we're also a very large state program, and it's also incredible for our state, right? We are drawing down that federal match. We are, avoiding what potentially could be kind of uncompensated care costs for our state and our local governments. And so I did want to take just a minute to show this and kind of tell the story behind it, which I think is simply the import of Medicaid. And then finally on our rate, we have a breakdown between nursing facility settings and non-nursing facility settings for COVID-19 diagnoses. This percentage has been going down over time. We know that kind of at the beginning in March and April, we did see, as is true across the country, kind of see positivity rates in nursing facility settings. But as time has gone on, obviously that represents fewer and fewer percentages of our cases in Virginia, and also is true national. All right, so I will let the show go on. I don't want to take any more time, but we will put out. We're digging more and more into this data because of the claims lag. It hasn't really been appropriate yet to kind of talk about what we're seeing in our data. But we'll continue to do so, and kind of early results here. But we will put out data publicly in the coming weeks and months.
Are there any questions for Ellen or for Karen from the members?
This is Patricia Cook. I do have one question. Ellen, do you have any numbers on access to testing versus COVID diagnoses?
Tell me how you're thinking about access to testing.
So I run a frontline testing clinic. So we've tested a little over 3,000 patients. We've diagnosed 400. So if you're running it off the diagnosis code for the actual illness, that's different than the suspected. And so that's what I'm wondering. Do we have a comparison of like our Medicaid members able to access testing?
Yeah, that's so kind of so we have testing data. So I will say,
sure.
We have testing data. We have for 90%, I think, of our tests, our lab data. We have kind of the data behind that. So whether the test comes back positive or negative, in addition to the diagnosis data. The question in terms of access, we could run this, think about, okay, what percentage of Medicaid members have received a test? In our data, that's kind of hard. We do know that I would venture to guess that a fair number of our Medicaid members have received tests, but not necessarily been kind of billed to Medicaid. And so, but we could run those numbers and see if they're kind of similar to the testing rate of the population writ large. That's something we could do.
I think that would be great, just to get a sense, because I hear from patients they're having trouble getting into different.
Okay.
There are some places that are insurance specific testing sites, like some of the urgent care clinics and things. Mm-hmm. And so I just wonder, is that a barrier for our patients?
Yeah, it's certainly something we can take a look at. I mean, Medicaid has from the very start, covered testing. But yeah, that is certainly something we can take a look at.
Are there more questions for Ellen? Are there more questions for Ellen? I've got one very quick one. How are our nursing homes and also private providers, especially those that are in the home, are they able to get do we have any sense of whether they're getting adequate PPE at this point?
Actually, this is Karen. Tammy is on the line, Tammy Whitlock, Deputy Director of Complex Care, and she also monitors a subcommittee group that works with long-term care providers. Tammy, do you have any additional thoughts on comments on the ability? I know that it's a constant struggle for people to obtain it, and they have to go internationally, and we even experienced it when we were working to obtain PPEs for the consumer-directed attendance, that it has to go international, and then they're also demanding payment up front, which is unusual for us, and we had to get special permissions from the Department of Accounts to prepay for items that we had not received yet. So, Tammy, would you like to add on to that?
Yeah, Karen, just that we are constantly hearing that on the long-term care calls, that I think some of the nursing homes have made some great strides in getting getting the PPE. Others have not. They are still struggling. The home care agencies are struggling. Everyone seems, and on the DD waiver side, the DD group homes are really struggling to get those. Those are the horror stories that we've heard, where they have demanded more money while sitting in customs, waiting to get across to the United States, and they won't ship them until they get more money. I mean, it's just consistently hearing horror stories from providers.
Thanks. I was hoping to hear something different, but when you're operating under the Articles of Confederation, when it comes to this, it's without national leadership, it's hard.
Yeah.
Are there any other questions in this area?
Mike, I had a quick question for Ellen. Ellen, I was going through the nursing facility data. We saw 77% is diagnosed in nursing facility. I was just trying to reconcile that with our population of COVID, with children, pregnant women. How do we think about that? If 77% of our diagnosis is in nursing facility, I was just trying to, maybe I'm not connecting the dots.
Not in a nursing facility.
I'm sorry?
75% not in our nursing facility.
Oh, not in nursing facility. Okay, sorry. My bad. Thank you.
No worries.
Should we, can we move on at this point to the budget update?
Absolutely.
Yeah.
I'm going to turn it over to Chris. So our CFO, Mr. Chris Gordon. So, Chris, the floor is yours.
Thanks, Director Kimsey. Just confirming, Director Kimsey, you can hear me before I get started?
Yes, Chris.
Perfect. Okay. So, next slide, please. There were three things that we were requested to speak on today to the board: state revenue and the impact on the budget. The second thing was the COVID-19 provider payment increases. And the third was the FY21 budget to actuals for the agency. So we have 6 slides that we're going to speak on today on that. So next slide, please. As Secretary Lane, he's our Secretary of Finance for the Commonwealth of Virginia, noted in his remarks to the General Assembly when they convened with the special session, the Commonwealth is facing a $2.7 billion, that's with a B, $billion shortfall in revenue, and obviously that's due to increased unemployment and businesses that were shuttered primarily due to the stay-at-home work orders, so they weren't able to submit or pay taxes, which is where we, as the Commonwealth, get our general fund dollars for all of our work that we do on behalf of the 8 million plus folks that live in Virginia. So as terms of how that impacts the budget, they convened a special session in August 18th. As proposed, there were no reductions to the DMAS agency budget, and by that I mean there were no operational reductions to our administrative budget. We have a $270 million administrative budget. There were, as every agency experienced, all of the medical non-administrative amendments were reverted and swept. So all of the money, all of the funds, all of the programmatic activities that were passed during the original General Assembly session earlier this year, all of the funds and the language attached with that were swept. So it's as if we're back at January 7th, the day before the General Assembly started back in the spring. What is happening in terms of funding with our medical budget is we have utilized, I think we mentioned this last time, the previous meeting, we receive enhanced federal medical assistance percentage. So that the convenient acronym for that is FMAP. And the federal government back in March passed a public health emergency order that allowed the states across the country to receive bumps in their FMAP, approximately 6.2%. So that increased the federal amount, the federal match that they gave us in Virginia and reduced our state general fund share, or in the case of Medicaid expansion, the coverage assessment or special funds share. So that freed up in the January through March first quarter of this year of FY20 in calendar year 2020, but in FY fiscal year 20 quarter 3, it freed up $337 million in general fund that was returned back to the state. Those monies were reverted to basically central accounts where they were used and are used now and can be used to fund other state priority initiatives for the administration and the legislature. In FY21, we're in now, so it's still the same calendar year, just different fiscal year, state fiscal year. We only returned, they've swept as part of the General Assembly's introduced budget for the special session. They swept $128 million in our general fund and returned it to the state based on the continuation of the Health and Human Services Secretary Azar's Declaration of Public Health on July 25th that goes through October 24th. They swept the first quarter and they also swept the second quarter. And for clarification, whenever these federal declarations of public health emergency occur, they run for 90 days approximately, and whatever quarter in which they end, the FMAP will continue to the end of that quarter. So we will continue if they don't renew, if Secretary Azar in October doesn't renew the federal declaration of a public health emergency, we will continue to get FMAP through December 31st. And two questions should probably come to light in terms of seeing this information. One is, why did we only return essentially a little over $200 million for 2 quarters when we returned, $337 for 1 quarter back in FY20? And the reason is the first bullet right there where it says MOE is higher due to greater enrollment. So as you heard Director Kimsey mention just a few moments ago, we have 136,000 more people on Medicaid than we did since the start of the pandemic. That is more than we forecasted. That is more than we expected. As a result, the Commonwealth Medicaid is paying more for these people to receive access to health care services. So because our maintenance of effort, and that's the term we use, when the federal government is giving us the 6.2% enhanced FMAP conditional upon our continuing folks, existing folks and new folks in Medicaid, when otherwise they would drop off due to changes in circumstances, et cetera. So we have a higher maintenance of effort that's going on, which is resulting, and that's why we're returning less general fund to the state now for 2 quarters, for 6 months, than we did in that third quarter in FY20. So that's important, or I should say the fourth quarter in FY20. That's very important to know. The other thing that's important in figures in here in terms of future spending as we get ready to release the October 15th preliminary forecast and the November 1st actual forecast is that whenever the Health and Human Services Declaration of Public Health Emergency expires, again, we will get continued FMAP through the end of that quarter, whenever that is. But at the same time, we have to then begin dispositioning each of those folks that are those MOE folks, those maintenance of effort folks. So Chief Deputy Muntz, Acting Deputy for Administration, Sarah Samick, myself, have convened last week. Actually, Sarah Samick's team has been working on this actually for several months on what rolling that off looks like, because there will be financial implications to that. And we're trying to account for that in the forecast. And so we are mindful of that, and we're collaborating as a team to get a better sense of that. Next slide. The second topic that folks wanted to hear about is, what have we done for our provider payments to the provider community? And a lot of folks that are board members here are providers, as we just heard from one of them asking a question to Dr. Muntz. So we have several slides here, 3 slides that speak into what we've done for those folks. So the first slide here is talking about what we've done for long-term services and support. So LTSS is the term of art we use, and those are primarily for nursing facilities, and I'll mention in the second bullet, assisted living facilities. So early on in the pandemic, towards the end of March, we were approached by the administration, and we were requested to provide $20 per patient, per member, per day to each nursing facility as a supplement, because early on they recognized that the nursing facilities were the front lines of the pandemic, and as a result, they needed more financial support too, as Mr. Cook, you mentioned a second ago, for PPE and things like that to battle the pandemic. And so DMAS responded very quickly, and Director Kimsey was very involved, Deputy Whitlock as well, in working with our managed care organizations. And the value of that is we actually were able to fund all of that extra payments to the nursing facilities completely by the MCO underwriting gain. And just to decompose that simplistically for folks, when we have a capitated plan, as we do, we make payments the first Friday of every month to all of our 6 managed care organizations in the order of, hundreds of millions of dollars each month. And we pay that out based on what we think the actual healthcare experience of our members will be. As everyone knows, everything shut down in March, April, May. As a result, people were not receiving healthcare, yet we were still paying our managed care organizations under the assumption that they would have a certain level of healthcare experience. So as a result, that increased their underwriting gain, which is a nice term for profit. And so knowing that they had that increase, we collaborated as a team to utilize those funds, request and do a contract modification to utilize those funds so that they would direct it towards this specific administration requested initiative here. So that's why we've done this, and we continue this now. So March 12th through June 30th, they used MCO underwriting gains. That was fiscal year 20. Now in fiscal year 21, we increased the rates that we pay to our managed care organizations to compensate for this amount. So they will continue paying this $20 per month to every Medicaid receiving facility, nursing facility that has Medicaid patients. So they continue to do this. All of our managed care 6 entities continue to make those directed payments. And that is funded 50-50 with our standard federal financial participation and general fund via the fee-for-service and capitation payment. So it's matched at that rate. Again, it's still the 6.2% FMAP. I'll note there. The second entity, and this actually is a more recent development in a payment to a provider community, is an enhancement using CARES Act funding for, again, our nursing facilities and assisted living facilities. And I should note that this is not, and I'll repeat, not limited to Medicaid nursing facilities or assisted. This is a nursing facilities writ large, so all 260-plus nursing facilities and all assisted living facilities in the Commonwealth of Virginia. So this is not just Medicaid. It is the whole universe in the Commonwealth of Virginia. And the state, as you know, received CARES Act funding from the federal government. The administration allocated those funds, and directed our agency, DMAS, to provide money to these two provider groups here, licensed nursing facilities and assisted living facilities. The funds have to be spent by December 30th of this calendar year. And we are, as directed by the administration and the receipt of these federal funds, to compensate nursing facilities and reimburse them and assisted living facilities for any COVID-19 expenses from July 1st through October 31st. And we have a short stop on that, October 31st next month, because we have to complete expenditure of all of our funds by December 30th. And so we'll allow those nursing facilities and assisted living facilities to submit reimbursement claims into our vendor, Myers & Stauffer, MSLC is the acronym we use, Licensed Limited Corporation. MSLC is processing that and working this on our behalf. So they are receiving all these reimbursement claims and reviewing them and actually providing approval, and then we're issuing the payment. And again, it's a reimbursement, which means we are reimbursing actual cost. It's not a prospective, it's not a payment like the prior 20-day per day member for nursing facilities. The key with this is it again is not limited to Medicaid, so it's everybody in a facility, any resident in a facility, it's all of them. And the trick is they have to use their COVID-19 funding first. Other COVID-19 funding first. So the nursing facilities specifically have received about $153 million in CARES Act provider relief funds. They must use those funds first. They also are receiving from us, as I mentioned in the bullet above, the $20 per day per member dollar. And so for those facilities that have Medicaid members, they also have to offset that as well. And then as Deputy Whitlock and her team, they oversee the Civil Monetary Penalty Fund within DMAS, and with that, we basically collect revenue from nursing facilities that are in CMS finds them to be not in compliance with certain standards. We collect those revenues and we use it to fund projects. And one of the projects Deputy Whitlock's team has done is the $3,000 per facility for access to high-tech, so laptops and things, iPads and such like that, so to facilitate like a member communication with their families. And so all of that money cannot be included as this. So think of as the CARES Act funding as sort of a payer of last resort. The funding, again, is capped. Our total cap is there. But if there are any unspent funds, my senior advisor, Thomas Gates, and Bill Lassard, who's Director of Provider Reimbursement, we'll be collecting those and looking to see how we can fund any excess dollars if there are any unclaimed or unfunded, unreimbursed expenses. So they'll be looking for that. So this is an ongoing project, again, that Finance and Tech is doing. Next slide. The other Medicaid provider relief efforts that our agency has undertaken is in the realm of the evaluation and management services. So at the same time, in the final quarter 4 of FY20, so April through June, we also realized because we did the $20 per day per member for the Medicaid nursing facilities, we also recognized fairly early on that there was also headroom within the capitation rate we paid to the managed care organizations to provide relief for our primary care providers and other entities that otherwise would do evaluation and management. So the face-to-face interfacing activities that currently weren't happening at that time. So we did a second contract amendment for all of our managed care organizations to utilize the headroom there within their profit, essentially, because they weren't providing access to medical care. And that was a 29% increase in Medallion, again, our Medallion 4, not our complex care program, but Medallion 4.0, which is where we saw most of the headroom there. And so that, again, was just for the period of March 1st through June 30th. That was funded by existing MCO managed care organization underwriting gain. And again, just for Medallion 4, not CCC+. The other category, there was a lot of headroom. we were shut down, if everyone recalls. And so there was a lot of capacity within existing funds that we already had to redirect the MCOs to support this. And so the other was, and Tammy Whitlock's team, Deputy Whitlock, led this effort. And the Evaluation and Management Services, I neglected to mention, was led by Chief Deputy Muntz and the Health Economics team. The next two were Deputy Whitlock in Complex Care for the adult day health care and the day support for the DD waivers. And these were essentially retainer payments that were paid at 65% of the full rate. So recognizing that adult day health cares, in order to whenever everything was shut down, in order to have a network to come back to, recognizing we will come back out of this eventually, and we've sort of crept out turtle head a little bit slowly as we move forward. We have to sustain the existing network. So Tammy's team recognized that early on and began work on Appendix K activities, which is the term of art from a CMS approval, from our waiver that we have from them, to provide retainer payments to the adult day health care and the day support for the DD waiver population. So those, again, were paid at 65% and covered the period March 12th through July 31st. These, again, were existing funds. We did not have to ask, and we did not need existing funds for this. Again, for fee-for-service, for the adult day health care, that was the unspent FY20 Medicaid funding. We had already predicted and planned and forecasted that we were actually going to spend this on that, and so this allowed us to expend those dollars. And then again, for the managed care population, the underwriting gain, the profit in CCC Plus, similar to the evaluation of management we did on the other side for the primary care providers. And the same with the day support as well. Note there that there wasn't any MCO funding for that. It's fee for service 100%, but again, we forecasted that, so we have the funds available. And again, we pushed the money out the door at 65% of the full rate. Next slide. These are other, not necessarily COVID-19, but our payment rate increases that we wanted to bring to your attention for this year. Specifically, all personal care providers or personal care attendants, or PCAs is the acronym we use. We provided a rate increase for those, and that's Deputy Whitlock's team oversees that program, and that's for the consumer-directed population as well as the agency-directed. So we have certain Medicaid members that require personal care attendants to provide support to them in the home. And we provided a 5% increase. The General Assembly did not, and the administration did not unallot those funds for this General Assembly session. So we did fund them a 5% increase this year so that they could increase their respective wages. And that was, again, appropriation provided by the General Assembly. The last inflation adjustments we do for all of our provider communities, hospital payments were increased by 2.4%. Nursing facility were increased by 4%, 4.1%, and that is in addition to all of the other pieces that we've spoken to here. Home health payments were increased by 2.6%. Outpatient rehab agencies, inflation up to 2.8%. And all of that was funded by the standard federal financial participation, again, with a 6.2% FMAP via general funds through either the fee-for-service model or the capitation. The last slide, next please, is you wanted an update on basically our FY21 budget to actual. So apologies for this quick graphic here, but this is actually a really good time to point out sort of the intricacies of essentially the 5 fund types that we work with, because this is the start. This represents July. We won't have August until the middle of September. Actually, the prior month closes in the next month, by the middle of the next month. So this is just July data. That's all we have so far. And what it shows is that we were appropriated in the third column there where it says FY21 adjusted budget. We were appropriated under total Medicaid expenditures in $25,118,559. So this is a $16 billion program for this year. Again, that's absent any of those changes, all of the changes that were swept as part of the Medicaid program reversals that were actually stopped. All of those wins that we got in the General Assembly in the spring, all of those were set aside and reverted. So it's still $16 billion. That's our total medical expenditures for DMAS. Underneath of that, we get $9.6 billion from the federal government, from CMS, for this program. That is the majority funder for this program. It is not majority any other dollar fund type. It's primarily federal. The second category of funds is a rate assessment. This is where, and it's tied to the coverage assessment, if you will. Those two funds are where we collect taxes, 69 private acute care hospitals, to fund specifically Medicaid expansion. So those two funds are revenue funds. This means I don't have $477 million for the rate assessment or $373 million for the coverage assessment yet. I have to collect those funds. That's what I'm appropriated for. So our agency is appropriated to collect that much money, but we haven't collected it yet. So we can't spend what we don't have, and this is revenue we have to actually collect first. And the difference between the two, the rate assessment, is essentially the hospitals, the 69 hospitals, pay into this fund, and we make a directed payment back to them, which instead of providing just the Medicaid allowable, we bring it up to the Medicare allowable, which, as you recall, is Medicaid is a higher payer than Medicaid. So Medicare is higher than Medicaid. And so we bring this, we adjust, it's called the upper payment limit, and we increase their rate assessment payment back to them. So this compensates them for the care they provide to the population now that we have Medicaid expansion. The other is the coverage assessment, and that's actually dollars we collect from each of the 69 private acute care hospitals. Those are the actual dollars that we use to fund medical care for the expansion population. As Director Kimsey noted, that population has also gone up in excess of 50,000 folks since the onset of COVID. And so we are, the assessment for that, the appropriation there is pegged at 373, but we have the authority to exceed that if we need it. The next to last category there is the Virginia Healthcare Fund. This is also a revenue collection fund. We were appropriated $472 million, which means those are funds that go to offset the state general fund. And what I mean by that is the state has a vested interest in preserving its general fund. It inherently wants to maintain that and keep as much of that as possible. And so to do that, it replaces those state funds with the Virginia Healthcare Fund. So those are revenues that are collected from the smoking tax, for instance, or when the health department essentially goes in and enforces the smoking ban on indoor facilities and things like that. It's also funded by pharmaceutical rebates. And so when we get pharmaceutical rebates in the terms of prior year refunds or current year refunds, those all dump into the Virginia Healthcare Fund. Again, when we collect that money, we make the adjustment each quarter, and we use the healthcare fund revenues to substitute for the general fund revenue. So we maintain a general fund preservation strategy. And then last but not least, we have $5 billion in state funds, and I don't have to collect that money. I have that money now. That's in the kitty, if you will, now. The federal funds have to be drawn down, and the other three fund types have to be collected, but we do have the $5 billion in state funds. So year to date, obviously it's the first month in, and so there's literally less than 7% spent, which is on point for essentially where we should be. And we haven't spent any money in the healthcare fund yet because we only do that reconciliation once at the end of the quarter, and we haven't come to the end of the first quarter yet. And we haven't done any rate assessment expenditures yet because we haven't collected those taxes yet. And that's the reason why there's 0% spent in those two categories. And I'll stop there. Any questions?
Do any of the members have questions? Chris, I've got one, and you should answer this as carefully as you need to, but I take it we've given some thought as to what's going to happen and worked with the Assembly as to what's going to happen in the coming months as we move out of COVID, hopefully. and more people start going to physicians and more people start going into hospitals for services, which will send us back up to some of those increases and probably get less managed care funds, and also the potential of the MFAR regs kicking in. I've been told by folks at CMS that the administration is working hell-bent for leather, excuse my friend, try and implement those, although I suspect if, depending on whether the administration switches or not, that may or may not come to pass. But I take it you're at least focused on the potential adverse impact.
So there's a couple questions that you had in there, and I'll answer at least one of them, and I'll defer to other members, obviously, of the executive leadership team to speak into that. One of the interesting things that we do that Deputy Whitlock and Deputy Roberts do is they do quarterly meetings with each of the managed care organizations, and that's a very specific, small meeting. We actually had one yesterday with United, and they actually shared, just like they shared back in April when they were one of the very first managed care organizations to come to the table and say, hey, DMAS, we think we're going to have an unprecedented high volume or high number in our underwriting gain and our profit, and we'd like your help and to collaborate with you on how we might spend these medical dollars in terms of a directed payment. We actually had the same meeting with them, a quarterly meeting with them yesterday, and they actually were able to share with us that, yes, April, May, June, July, I mean, it fell off the cliff, as we know, but what they're seeing is that there's a longer tail than what they expected. They acknowledged that. The CFO acknowledged that yesterday in the discussions, and certainly I'll let Tammy and Cheryl speak into that since they were on the call as well. But what they're seeing from their lens, since they're on the front lines, and we get data from them, so they're seeing it first before we see it, is that the resumption is not going to be perhaps as quick as we initially thought. And by initially, we have no experience with pandemics. None of us on the call or in this meeting have experience with pandemics. So it was reasonable to assume that the first 6 months of this year would continue of the fiscal year, so July 1st through December 31st, would continue to be sort of down dog type years or months. And then we would sort of see an increase. And they, based on their current projections, they're not seeing, at least United is not seeing that increase right now. So to the question of are we planning for this, yes, as part of our forecast process. We've actually already met with Chief Deputy Muntz as well as Acting Deputy for Administration Sarah Samick. We had a call last week. We're already planning on what does that look like from a forecast lens, especially when does the FMAP end? When does maintenance of effort end or begin? And the 6-month thesis. So we have a lot of unforeseen things that are coming in that we typically don't. That just means that we're doing a lot more increased collaboration than we normally do. And it's not that the forecast is ever easy, but there's a lot of external factors that come into play. So, Ellen, did you want to speak a little bit on maybe MFAR or some other items that you've spoken to?
This is Karen. I can speak to as well. Michael, as you were questioning, there are several things up in play. And MFAR, we know what the scenarios can be, and we know we're prepared, but we're still in the process of dealing with our special session right now. Yeah. And I'm working through that. And as we move forward with our forecasting, we'll work very closely with the administration and our stakeholder partners as we look at the long-term impacts related to that. But right now, we're still working related into the special session, and we'll gear up for the larger session after we get past this one.
Yeah, hopefully you won't have to deal with it, but
we already have projections and available for the administration's consideration and the impacts and working on those. But as Chris mentioned, we're juggling a lot of what ifs in the air at this time.
Yeah, not an easy process. Karen, Ellen, should we move on to the next presentation?
Mike, I had a quick question. I'm sorry. I think I was
Sure.
coming out of mute. Chris, this is great presentation. Thank you. I had a quick question. Do you have an estimate of what the underwriting gain that we were able to use April, May, June for those different initiatives?
When we don't know what the utilization was because the plans actually don't have to provide that information to us until May of, essentially they get 11 months to provide that information. So we won't actually know until May of next year. But the plans, when we do the contracts and do the actuarial rates, we only put in a 1% profit typical a gain. Then obviously based on what happened, they experienced more than that.
Thank you. Thank you, sir.
Excuse me, this is Peter. Just also a quick reminder that due to the mega reg, unlike in prior periods, in Medicaid, subject now to the 5% limit. I'm sorry, subject to the medical loss ratio and admin loss ratio limits. So depending on what the overage is, some of that simply has to come back regardless. Now, if you can negotiate that in terms of potential forward increases in utilization, which my best guess won't start to ramp up until late spring or summer, maybe, then you may be able to carry some of that over in some form.
It will come in as revenue to us, and it will be dumped into the Virginia Healthcare Fund, and that will again offset general fund, and so that will have a positive impact on the forecast by reducing general fund pressure.
Thank you.
Are there more questions for Chris? Otherwise, Ellen, Karen, do you want to move on to the next presentation?
Sure, that sounds great,
Yes.
Cheryl.
Okay, good morning. My name is Cheryl Roberts. What we're going to do is Tammy and I are going to do a quick overview, well, quick with quotes overview. My section is going to talk about managed care overall, give somewhat of an education to the newer members of the board. And then Tammy is going to talk about the most complex care and most vulnerable population, especially in the focus of COVID. So we hope to get through some things you may have to ask us later to actually explore, because we're going to go through many, many topics. So next slide. Next slide. What we hope to do here is we talk a lot about managed care, but we want to show a couple of things in this demonstration. This whole, to look at it, is obviously we're surviving COVID. We are accountable. That's important, that we're just not giving the money away or contracting freely. We're trying to manage the program well and feel that we've been successful. And as Karen talked about, we're looking at the future, that this program is always evolving, and so it's never the same year by year. So in some ways, it's good to get an update. Next one. For people who don't know, it's common, is that we have two programs here. The CCC Plus program, even though CCC Plus has 260,000 members, that is our most vulnerable population, our most expensive population. It's where we spend the most energy and time in terms of coordination of care, and also has the most diversity in population. Medallion has about 1.2 million people. That's really where the population went. You have children, pregnant women, caretakers. Looks similar to a lower economic status of a commercial plan. And so many things that we do in terms of services are related to what you would normally see in a commercial plan. Next. One of the things people forget is that as much as we would love to believe that we DMAS and the board control everything, managed care is controlled by authorities. CMS is our first. We have to get waivers. Then we have the regulations. And in this case, you should know is Medallion and CCC Plus were procured, and therefore we're working under those procurements. But both contracts have that we have to also follow BOI, the Bureau of Insurance, and all plans must be NCQA accredited. That's very important when people ask questions about credentialing, and things like that. All that is tied to NCQA. Next. This slide is busy, but the point of the exercise is when we think of managed care, it really is a bigger scope of things. It includes compliance or program integrity, budgeting, network, behavioral health. What Tammy and I are doing basically is facilitating a mega system. It is not necessarily that all pieces are controlled by one person. We acknowledge that all our divisions contribute to managed care and the oversight of managed care, as well as the development of the program. Next slide. One thing people ask the question is, how does this affect the member? When members get a card, they start to get a card from us. We call it the blue and white card from Medicaid. It will probably be changing one day. How they get into managed care is important. They get a welcome letter, they get an assignment letter, and then the plan interferes. The plan then at that point sends out a welcome package. The member is then assigned to a plan. One of the things that is critical is that we have an enrollment broker. We don't talk about that much. That probably is a discussion in itself. The enrollment broker does many things. One, it actually is where the person goes and has a neutral party that they can actually ask about plans and get plan information, where we get our comparison chart. It also has the plans network there. And for Medallion, there is an app. And usually if I was there, I would make you all download the app, the Medallion app. And the reason I tell you to do that is it's not just because it helps you with selection of plan, it's a mobile network. If you wanted to have, or someone you're talking to, and this can work for anyone, you can actually look up the provider, or you can say, where's the provider in the zip code? And therefore you'll be able to do that with the app. You also have a website there. And as our group is getting younger and younger, particularly on the Medallion side, what we found is that people are less likely to make a phone call, and as always, more likely to use the website and the app to make their selection. And we're trying to adjust programs accordingly. So you're going to hear, even in the future, Instagram and how that plays a role, and different things that we're doing to actually reach out to the members. Then the member gets assessed. If they're in CCC Plus, they get assessed in much more detail. And then if they're in CCC Plus, they get a care manager. Same thing for foster care. Pregnant women get into a special program. And the big thing the member gets for being in managed care directly, otherwise than the care management and the network, extra benefits. Things that we take for granted, particularly on the commercial side, we actually get them from our managed care health plan. And so you should have that kind of concept, is that we're very, very focused on the member experience. Next. So who are the health plans? First of all, it is miraculous and wonderful that the same plans winded up winning both procurements. That normally does not happen. Michigan, for example, has over 20 health plans. We are grateful that we have the 6. So everyone who says, well, 6 is a lot, I always say, look at Florida and Texas, and you'll be shocked at how many they have. Anyway, one of the things we love in our health plans, and this much is that even though we have 6 plans, they are uniquely different. We gave you the numbers and where they are in terms of membership. They bring a competitive edge to each case. So it's not like you talk to one, you talk to the other. So whether you're getting the Anthem Healthkeeper and their leverage of their network, or whether or not you're getting United Healthcare's, at they're the #1 plan in the country, their expertise, our regional expertise that we get from Optima, Virginia Premier, each of them has a niche and a competitive edge. The 2 things I do want to tell the board is we are in transition with 2 of the health plans. In Magellan is in the process of being brought out by Molina. Okay? And at this point, Molina will be a full merger. However, because Magellan has a service agreement, they will not be changing anything, basically, their leadership, their name, or anything. They're acting more like a subsidiary for the next year or so. So even though you're going to see things and announcements about their merger, the name and things will not change necessarily until a little later. In Virginia Premier, that change is just about complete. In this case, Centera hospitals have brought Virginia Premier. 80% is owned by Centera Hospital, the health system, and 20% still by VCU. We are watching that transition, obviously, because that means the health system also owns Optima Health. We're trying to make sure that there are firewalls and protections. We're spending a lot of energy and time on that. But I just wanted you to know that we are clear of we're watching how each of these plans are being operated. Okay, next. All right. So people always ask Tammy and I, can you just add that to the contract? Actually, that's become our favorite thing. She and I have learned to say no in different languages now. No, in many languages. Okay, fine. The contract, I wish, was controlled by us. And there was a time it was, basically. And now it is really, truly an integrated community. Most of the things that we have in the contract comes from either the governor or the General Assembly. That's where the dictation comes in. And so that's where we put our focus on, both good and bad. Then we also talk to all those divisions. You remember all the balloons you had seen with all the different divisions? We have input from our divisions and our stakeholders about things that we see. So, for example, if Tammy has a long-term care work group meeting and they find there's an issue or problem, those things would also be addressed in these kind of input. Okay? Then we work with Chris. That's why Chris we're all tied together because things that are you putting in a contract have impact both in rates as well as systems as well as communication and effect. So the things that we do is we work with the capitation work group. We work with Mercer and the financials as we develop the rate. Then, of course, we have to have a negotiation season. So then we talk to the plans, and the plans work with us both on the rates and the contract language because we're in the middle of negotiations. It is not a dictatorial relationship. We cannot say you must do everything and not understand. Now, we do try in this whole relationship is to make sure that we are being accountable. So the things that we're asking for can be quantifiable. That's one of the things. Ellen makes sure that we can do some do we have the data for it? Are we able to measure it? Not that we have wish lists. People have things like wish lists. And one of the things we also try to tell people is that the right place to ask for the wish list? Is the plan able to do those things? And then, not before we go forward, we have the executive leadership. They all look over it and have comments and questions, and we make modifications. And then last but not least, it must be reviewed by the Department of Budget and Planning. We have learned and have become a great relationship with them. They do a thorough contract review, and they look at every line item. We have a theory. If it costs more than a penny, they're going to pick it up. So therefore, they have been very strict about that. We have learned a lot from that process, and then they give us the approval to move forward. Next step. All right, so how did July go? So this is going to be easy. First, the good news. This is the first time that Medallion 4 and CCC Plus on the same contracting and rate scale. As Karen mentioned, as we're starting to think about how to merge the programs, the first step is obviously to get them on the same timeline. And so this is the first step. So we were happy. March and April, we did that whole long list of things to do from contracting rates and budgets, and we did everything we were supposed to do. And then, surprise, May, the governor unallocated all the funds, and we had to remove everything that we had put in and take it out. But remember, we have to have everything done by July, so we were in a quick cycle, so that June we had to quickly go back to the starting point, do all those things in the cycle, get it done, get approved by DPB, and we are proud to say that we still made the timeline of mid-June, and we still were able to implement everything for July. We are very pleased. Next slide. Things that impacted both programs that you know. Number one, everyone knows this one. We implemented the hospital readmission and the ER reduction. I will not talk about why everyone knows. We will just say that became what we're going to be known for this cycle. We actually put in the MCO pharmacy benefit management spread pricing information that the General Assembly wanted. Because we started seeing mergers and acquisitions, we asked to change the contract so that we have much more disclosure and many more bells and whistles in that language for mergers and acquisitions. We have a payment target. The answer to the question is for value-based payment arrangements. We have a strong value-based payment team, and we've been working on that. We put something in for emergency and post-stabilization. One of the things we did was allow the plans to have Uber and Lyft. Again, changing how the world changes. And so We wanted the plans to be able to do that. And we did a lot of work on general alignment between the contracts to make sure that if, let's say, we have something here that says blue, if it could be blue in both places, we made it blue. Next slide. One of the things that we also did as part of the change, we made a combined contracting team, which is really actually superb. Tammy and I are both so proud of them. They're just excellent. Okay. What we did for programs, obviously, CCC Plus, they went to a different cycle. They increased the personal care. Chris brought that up. They changed some of the names for ongoing care, and they clarified some of the responsibilities, and they allowed nursing staff to conduct level of care. And in Medallion 4, most of the information was on the famous side. Next. All right, change. Obviously, COVID played a role here. To give credit, and Karen probably didn't emphasize, we had a whole team on how to do COVID changes. And Miriam actually was one of the facilitators. You're going to hear from her when she talks about health equities. And basically, we had team meetings to talk about what we're going to do. Tammy's going to spend a lot of time because most of them affected the most vulnerable population. But I just want to give you a sense of some of the things that were done in the middle of the COVID changes. One is missing, and actually the number one is missing, and I just picked it up. So it's telehealth. Believe it or not, we forgot that. That was the biggest thing we did. Probably the thing that was the game changer is how people were able to provide care. We're proud of that. We're probably going to continue that. You'll see that's what a big issue for a special session. Second one was transportation. Think about it. Now it's known, but how do you get people transported in the middle of a crisis? How do you get someone from a nursing home that's shut down completely to their dialysis? The transportation team here in DMAS worked with all the vendors, not just the fee-for-service, but also the managed care vendors, to make sure people got their care. We had dramatic stories in terms of one point Bill had called 7 people to beg people to get someone out of a nursing home to their dialysis. We had wonderful stories. Very, very proud of how they handled it. Obviously, we had to cease provider enrollment and audit activities because we wanted people to get in easy and quickly. We did some outreach efforts for pregnant women, especially on the equity issue, where Ellen, this is a case where I want to show how we work together. Ellen was able to pick up that pregnant women were getting affected. We were able then to start an outreach effort to go with it. So we all worked together to make sure that the data, it leads to an activity. Chris already talked about the increase there. And then Tammy and I made sure the plans met with us every solitary day. Okay. And the reason we had to meet with us every solitary day is because they had people on the ground. And so therefore we didn't have to wait for the utilization data. We knew what that data was looking like every day. They told us what cases they had. They told us where the issues were. We had someone on the ground. So between that and transportation, we could give daily updates of where everything was. And so that worked in a very, very good way. Next. Chris talked about the money, but I also want to talk about something else. What did the plans do to help address COVID? And one of the things we realized is that you could do 2 things. You could say, oh, well, and that's an oh, well answer. But instead what we saw was the plans, as I said, were on the ground. Lots and lots and lots and lots of delivery of food. I'm just giving you this, virtual baby showers, delivery of diapers. We just saw food banks, all this energy and money being poured in to get to the community. Next slide. One of them that was on my favorite was giving Chromebooks to foster care kids who were aging. If you think about it, what happens to you? Everything stops. How do you do that transition? Remember, foster care kids, a lot of them do not learn how to drive, don't have jobs. The idea of that people were actually reaching out to get them Chromebooks. And again, delivering food, lots of stories we heard. And so we were touched by that so much that Tammy and I want to share one with you. And with that, I'm going to stop my part, and Tammy's going to take over.
Thanks, Cheryl. So I know we are running close on time, but I will talk really fast just so that folks can see the video. Sarah's going to run it, but I think we're going to have the closed captioning in place because the sound is a little low. So, Sarah, I'll turn it over to you, and if you guys can just read along, you'll also get this so that you can play it yourselves and hear him talk.
And I am still working on pulling up that video, Tammy. It looks like it's frozen on my end.
Okay.
So I'm trying to refresh it real quick.
If it doesn't refresh, Sarah, we'll just send it out.
Let me give it one more shot.
Okay.
Yeah, I agree. This is Karen. It can be sent out to the board if it doesn't pull up.
Can you see the screen?
Yes.
Yes, we can.
All right, I'm going to turn the captions on. Let's give it a shot.
Jerry is just the best thing ever happened to me in my life. She's been like an angel. I mean, she doesn't have to do what she's done for me. But she took it upon herself to help me.
I first became aware of Dennis when his name appeared on my census. Every day I'm checking on those patients and making absolutely sure that their healthcare needs are being met.
Jerry absolutely knew the medical challenges that Dennis had, and so she was determined to make contact with this member because she knew she could help him. But we had a lot of trouble trying to locate Dennis.
I decided to see if I could track it down. I called the pharmacy where Dennis had prescriptions filled. They provided an address. So I go to the home on file, and the lady answered the door, and she said, he doesn't live here. He's homeless. He lives in the woods near the concrete.
I had a stroke, and my sister helped take care of me. And she died, and I started staying anywhere I could because of this. Didn't have nobody or nowhere to live.
I was not going to be able to rest peacefully knowing that this is where he was sleeping.
We talk often about meeting our members where they are, and that's exactly what she did.
This is the exact location where I first saw Dennis holding up a sign asking for help.
I don't know how she found me, or when Jerry asked me to come over and talk to her for a minute. I said, sure.
The first thing she did was invite him to lunch. She was able to take him to a diner, sit down, and start building that trust.
One thing that he did smile about was this relationship that he had with his godson, Jacob.
Jacob has been everything I could ask for. He's been my own son. And I want to be the daddy that he never had.
Dennis had type 2 diabetes, cancer, and he was treated for depression. I told him that Jacob needs a healthy godfather that is going to be there for him. Over the next 45 minutes, we were able to complete our person-centered support plan. It's a key part of what we do at Anthem to get him back on the road to better health. Of course, housing was at the top of the list.
If you don't have housing, you're not worrying about what your blood sugar levels are. You're not worrying about your blood pressure.
We were able to contact the local housing authority, and there was a unit available. So we were celebrating the parking lot. In 2 days, he could move into residence in Newport News. Hey,
what are you doing?
I attend every primary care appointment. When his doctor asked him questions, he would look at me for answers. That's probably the prescription that's waiting in the pharmacy for you. So,
Alcoholic.
Anthem included his care plan, access to a primary care provider, access to specialty care, and all of the other long-term support services, like a support person that he depends on every day.
Healthy baby, wash clothes, cook meals.
Transportation is a big challenge in this population, and so we'll take you to the pharmacy to fill your prescriptions. We'll also take you to a grocery store so you can buy fresh vegetables and healthy foods.
I'll break up, so you can add a little weight.
Once you empower patients, they really take ownership of their health and feel in charge again.
I feel better. Oh, my leg. On Sundays, I eat clean dollar food, drink a bath, watch the Fridays, basketball, the old time, getting in my walk.
I think Dennis' whole life has really changed as a result of Terry's intervention.
It's the other one was to get away, sit with them.
I don't see myself as an agent, but I'm happy and grateful that he continues to take control of his health care. The persistent support plan really works.
I just can't say how much I thank you for.
Thanks, Sarah. Thanks for doing that. Sorry about the audible part of that, but I hope you could get what enough from the closed captioning. It always makes me tear up. So it's just, I've seen it a million times, and I still do that. So Sarah, we can go to the next slide. I'm going to push through this fast so we can get to Miriam. Next slide. So I think we talked back in the last meeting about what we had done initially for COVID, and what we have done with a couple of new memos that went out on August 5th, and then I think another one on the 11th, is extend those flexibilities. So through the emergency, the 1135 waiver and the Appendix K that Chris talked about earlier, we've extended a lot of the flexibilities that we had in place through October 22nd for the 1135. The following flexibilities have been extended. Next slide. So for the 1135, individuals who choose to move to a nursing facility directly from a hospital can still be accepted without a screening. The nursing facility still has to ensure that member has meets the requirements, and the hospital still has to give choice for where that member wants to go. We have not seen an increase in members moving directly to a nursing facility, but this was a flexibility that we were able to provide, and it has reportedly helped out the hospital screening teams considerably. In addition, the pre-admission screening and residence review, the PASSAR, if you've heard that, they're level 1 and level 2. They are usually conducted within 14 days of admission, and we have allowed that to extend to 30 days to give the nursing facilities who have been really hard hit in this pandemic some additional time. Next slide. Also in 1135, there's an MDS, the minimum data set that nursing facilities have to complete, and that is also due within 14 days, and those are able to be done in 30 days. And nursing facilities normally, when someone is in a nurse aid program, they have to do that within 4 months. And if they don't, they have to discontinue that person if they don't meet those qualifications or able to get the certification. Some of the certification requirements were actually suspended during this time, so we allowed the nursing facilities to keep those employees on their payroll, number one, to make sure they had staff, but also to make sure that staff didn't lose their jobs during this time as long as they still met the skills and were able to perform the techniques. Next slide. Also in the 1135, we waived the in-person supervision by a registered nurse that has to occur every 2 weeks for home health, as well as the in-person supervision for hospice. This was something that was specifically asked for by the hospice and home health folks to help alleviate some of their burden. We do encourage that telephonic supervision occur, and I think most of the organizations have indicated they are doing that. In addition, the home health agencies can perform certifications or initial assessments by telephone or via video communication in lieu of face-to-face visit. Next slide. DME providers can now have been able to, and we're extending this, been able to deliver up to a 1-month supply at a time instead of a shorter supply. They can extend that so they don't have to go to the home as often. We're also allowing NCART, the National Coalition for Assistive and Rehab Technology, recommendations for remote protocols specifically for ventilators and other complex rehab equipment. We have followed that and allowed our providers to follow that. Telehealth visits are also allowed for therapy evaluations unless there's a situation where the therapist just does not feel that they can make that a complex evaluation over the phone or via telehealth, via video. Face-to-face requirements for authorizations of durable medical equipment for specific codes have been waived, and we have continued that, and so have the plans. We've pushed that out until the mid-October, October 22nd. And for short-term oxygen coverage, we have allowed that coverage that we don't normally allow for specific acute situations as COVID patients coming out of hospitals need that short-term oxygen coverage. Next slide. We are extending the certificate of medical necessities, which are used for durable medical equipment. The need for those has been temporarily suspended until the end of the state of emergency. They usually have to get those redone at every 6 months to a year, and so we have suspended that right now because that is usually something the physician has to do or the DME provider has to initiate. In addition, we've suspended the initial requirements for new orders. As long as there's an order in place, the provider does not have to get a new CMN, which sometimes requires a lot of paperwork, and with providers not being in the office as much, this was a flexibility we could offer. But they do still have to have verbal orders from the physician or the practitioner that includes the member's name, what's been ordered, and the diagnosis. And these will be looked at on audits after the emergency is over. Next slide. So we talked a little bit about Appendix K. Appendix K is what we use for our waivers, our DD waivers, and our CCC Plus waivers to allow flexibilities. Next slide. A big one that we were asked to do is to temporarily allow spouses and parents of minor children under the age of 18 to be able to provide personal care and be paid for those services through these waivers. That is extended. These flexibilities are extended until January 28th. That is a CMS date. That's not our date. We don't usually do things before the end of the month, but that is just actually it's the 26th. I'm sorry, I said 28th. But that is the date that this will go through to the end, almost the end of January. Next slide. Also for Appendix K, we are allowing a lot of telehealth to occur, specifically for assessments or planning meetings or evaluations that usually are done face-to-face. We are allowing these to be done by video conferencing or telephone. In addition, we're allowing the MCOs that flexibility too on care coordination and case management to make sure that their staff and our members are safe, that we're allowing them to do telephonic or video conferencing in order to conduct care coordination. Next slide. And for therapeutic consultation, this was also something that people had asked for to be done via telephone or video, unless the person who is doing the consultation just feels like that cannot be done safely to provide the services and the evaluation for that member. Next slide. We are on the DD waiver side for in-home support, community engagement, and community coaching. Beginning on August 15th, we are allowing new service authorizations for those services to be conducted through telehealth, because prior to August 15th, service authorizations that were in place on March 12th were the only ones allowed to be done via telehealth. And these are going to go through October 31st. for this waiver. We'll reevaluate that, and if we need to extend that, we will. Next slide. So for behavioral health, we've allowed a lot of telehealth flexibility. We've allowed telehealth for most of the services. We do know that there's been an uptick in a lot of the counseling services, which is great, as well as some of the arts services in behavioral health. And we do consistently, even though this has opened up some since July, we have reminded our providers consistently that they can still do telehealth. They do not have to do things in person based on what's safe for them and the member. Next slide. This is a document that you may have seen if you've gone out on our website. We did provide some resources for behavioral health for our members, and we've sent this out through a lot of our organizations that deal with behavioral health as well as our health plans. And any time that we can post this or send this out to members, we do that because it does offer some crisis assistance and where members can get help nationally as well. Next slide. And as I said, the intensive outpatient restrictions for our arts program have been lifted to allow telehealth therapy, and we have gotten extensive feedback on how this has opened up services and allowed members to continue to get the services they need for that program. Next slide. PPE, we talked a little bit about that at the beginning. We did distribute about 120,000 cloth masks by mail to all Medicaid members who receive consumer-directed services back in August and July and August. And then starting next month. It is this month. Starting September, employers of record will be able to order additional supplies. We have been able to secure over 18 million gloves, as well as over 5 million disposable masks and hand sanitizer. And we will be sending out communications for how these can be ordered. I'm hoping that we can do that before the end of this week, but definitely by the beginning of next week. We hope to have this available by September 18th. Next slide. And Chris talked a little bit about retainer payments. These are the numbers that we have paid to our adult day health care and our day support providers in the form of retainer payments. We are working now internally on some CMS guardrails that have been sent down that we want to be able to, of course, comply with CMS, but also make sure that our policies make sense and that we can communicate that to our providers. So stay tuned. We will be sending something else out on the retainer payments. But those have ended, and this is how much we paid. Next slide. So for DSNP, just a real quick, we dual special needs. This is Medicare and Medicaid members. As of August 1st, we have about 40,000 DSNP enrollees, and that's about a 34% increase since last year. 65% of that 40,000 are aligned, which means they have the same plan for Medicare and Medicaid. This often, if you guys remember the CCC program, this really helps with reducing fragmentation. Sometimes we can get to one card. This is what we're pushing for with our DSNP program. Next slide. We started in January to do default enrollment. So if someone is in a Medicaid plan and they become Medicare eligible, the plans we are able to put them into the same plan for the DSNP program. They can always opt out, but as you can see, we had about 1,100 members that were enrolled by default enrollment with an opt-out rate of about 4.5%. So we are trying our best to move towards alignment as much as possible. Next slide. This is just more information on the DSNP that we are moving to FIDE-SNP. However, considering we didn't have the funding available and the language available until late, we only have 2 plans that are doing that starting next year. The other 4 will move to FIDE-SNP, which is just more alignment and integration. They will move to that in calendar year 22. So stay tuned for that. Next slide. And then Karen mentioned the Cardinal project. We are looking to, of course, we have the report due November 15th, and we are looking to hopefully merge the contracts for the contract period of July 1, 2022. So again, stay tuned for more information on that. And that's all I had. Miriam? pass it over to you.
Okay, Miriam dropped off my panelist list. Give me just a moment to get her back on. And
actually, I'd like to ask a question because I'm mindful, this is Karen, of it's almost noon. It's about 6 minutes out. I'd like to ask the chair and the co-chair if this is something we wish to continue moving forward on, or we can bring it up at the next board meeting, because I'm mindful of the time and also the time of others. And you have our firm promise that we'll work on having more brief presentations in the future to make sure we can get to everything, but we're doing so much. That's wonderful. At the same time, I'm also very mindful of everyone's time. And in the 2-hour component, we could also set up a separate time with the board members to present on this particular issue if the board members are so inclined to not wait until the next meeting to hear about this. I just wanted to present it as an option for consideration.
Karen, first question for you. In terms of your time and the staff time, if you want to hear the equity presentation today, is that something that you can accommodate without too much difficulty? If not, I'd tell you that would work. Although I must tell you that equity is something that I don't know about others I care about deeply, but we can certainly wait.
We all do. We care very deeply as well. I agree, but I would not. My only inclination would be not to see the meeting go past 12:30 at the latest, just because I know there are other commitments, not just for our team, but for the members of the board. But if you'd like to ask the board members, we're happy to stay on a little longer, but I would not like to see it go past that.
Sure. If nobody has any objection, Karen, I'm fine with just moving on and holding this topic till the next meeting. It sounds like it could be more of a problem. Cannon, your call.
Yeah, I would prefer. I mean, because I'm also extremely interested, and I think if we can do it next session, I think we can have a more better discussion.
Are there any objections from the board members?
I will need to drop off at noon.
No, I mean, Peter, is it okay with you if we postpone it until the next meeting?
It's fine to postpone it, or you can continue, but I have to drop off.
Sure. Karen, anybody else object to postponing it? Anyone else? Karen, go ahead. We can reserve this until the next meeting. I have only one request. Any chance of cloning the care manager for Jacob?
Oh, well, yes, she is amazing, isn't she?
She's amazing.
There are many, many more like her out there in the system helping our members.
And then, Karen, would we get that video that we saw?
Sure. Yes, okay. We're happy to send it to you.
Actually, can you send the whole the group of presentations to the members?
They should arrive to you. Yeah, I'm not sure why they have.
No, we have the presentation. I got the presentation.
Oh, you did?
Yeah, I sent those earlier.
Then I must have. If somebody could resend it to me, I apologize. I don't think I got them, but at any rate,
we'll be happy to meet you, Michael.
Thanks. Could be me, my great technical competence as well. Is there, Karen? Is there? Do we have time at least to go for public comment if we've got any questions?
Of course, yes.
Is there anyone from the public who has a comment or wants to speak?
Mr. Cook, no one signed up for public comment today, so.
Okay. In that case, I guess we're coming to adjourn, and I just have two very quick reminders. If there could everybody send in their current contact information as a reminder to Brooke. If anyone has any comments or wants to talk about the the retreat, feel free to reach out to me or to Canon. And other than that, I just want to really thank the DMAS staff. You guys are doing, as usual, nationally, if you ever ask anybody at any conference about DMAS, they will tell you that they do an inordinate amount. Great job. Less resources than a number of other programs. You guys have just been fabulous, as have your staffs. Does anybody else have any comments? Can I get a motion to adjourn? Hello?
So moved, Cameron.
Can we get a second?
Second.
Thank you. Then meeting is adjourned. Thank you again for your.
Thanks, everyone.
Thank you so much. Thank you, everyone. Have a lovely day. Take care.
Bye.
Bye-bye.
Bye-bye.
And this officially ends today's session. Have a great day.
Thanks.